50% of COPD patients die within 4 years of their first severe flare-up. And when I tell patients that in clinic, the first thing most of them say is, why didn't anyone tell me this sooner? Because by the time most people are diagnosed, they have already passed through 2 or 3 phases they never even knew existed. And the phase where your choices change everything is almost always the one that gets missed. I am Dr. Suman Paul, respiratory consultant in the NHS and in private practice. In 15 years of treating COPD patients, I have seen one thing consistently. Many patients knew their COPD stage. Almost none of them know their gold ABE group. And that number, not your spirometry result, is what tells the real story about your risk. Today, I'm walking you through all 5 phases of COPD. Stay with me to phase 2. What the data shows there changed how I manage this disease in my practice. I had a patient come to me last year, 63 years old, former smoker. She had been told at her annual reviews that her COPD was mild and that she was managing well. She carried a blue inhaler in her handbag. She went to her GP. She did everything she was told. But last November, Margaret ended up in hospital, a chest infection that would not clear. 4 days on a ward, drip in her arm, and when I reviewed what had happened, the same thought came back to me that I have in clinic more often than I should. She had been passing through the stages of this disease for 6 years, and nobody had ever sat down and drawn the full picture for her. She looked at me after discharge and said something I hear again and again. Why did nobody tell me this sooner? Here is the number I want you to hold from the very start of this video. Half of all patients with COPD die within 4 years of their first serious flare-up. Not their diagnosis, their first hospitalization. And the research that produced the survival curve is not ambiguous. It is one of the most replicated findings in respiratory medicine. And here is what makes it so difficult to accept. Most of those patients passed through a phase, a specific identifiable phase, where that outcome could have been changed. They just did not know they were in it or what it meant. Today I'm going to give you the full picture, all 5 phases, what is happening inside your lungs at each one to change what comes next. Before we go further, I am a doctor, but I am not your doctor. This video is for education only. If you are struggling to breathe right now, please call 999 or see your doctor. But before any of these phases, there is something you almost certainly have never been told. Something that changes everything about how COPD risk is actually measured. And without it, the rest of this video will not make complete sense. You have probably heard of gold stages 1 to 4. Mild, moderate, severe, very severe. Based on your spirometry, the breathing test that measures how much air you push out in 1 second. Most patients treat that number like a sentence. Stage 2, moderate. That is where I am. But here is the part most patients and even some GPs are never told. That number measures airflow limitation on a single test day. It does not measure your actual risk. It does not drive your treatment escalation. Something else does. That something is called the ABE classification of COPD, and it works like this. Group A, low symptoms, no COPD flare-up in the past year, and no hospital admissions. Group B, high symptoms, breathless, limited daily activity, but still no hospital admission history in last 12 months. Group E, 1 or more moderate flare-up in the past year, or 1 hospitalization, either one. Here is what that means in practice. I have patients at gold stage 2, moderate on the breathing test, who are group E. They need more aggressive treatment than some of my gold stage 3 patients in group A. Their spirometry looks better, but their risk is higher. Your gold stage is one piece of information. Your exacerbation history is the real story. And that distinction comes back at every single phase we are about to cover. Before I go further, just wanted to clarify this. I am using the term phases of COPD to explain the progression of the disease. Please don't confuse this with gold stages of COPD. So phase 0. This one has a name most people have never heard because it sits before any COPD diagnosis exists, and that invisibility is exactly what makes it so dangerous. Modern respiratory medicine calls this pre-COPD. You are a current or a former smoker. You have a cough that has lasted longer than it should. You produce a little more mucus than you used to. Chest infection seems to drag on, but your spirometry comes back normal. So you are reassured and you walk away. But something is already happening. Chronic inflammation from years of cigarette smoke is beginning to narrow the small airways deep in your lungs. Airway wall thickening, early lung tissue changes visible on a CT scan, years before a standard breathing test could catch anything. Your spirometry looks normal because your larger airways are compensating, working overtime to cover what is already being lost deeper in the lung. Now, a word on something called PRISm, because it comes up and people confuse it with pre-COPD. They are not the same thing. PRISm is when your FEV1 has already dropped below 80% of what it should be, but your FEV1 and FVC ratio is still normal. You do not yet meet the criteria for a COPD diagnosis, but your lung function is already impaired. PRISm sits between pre-COPD and a full COPD diagnosis. It is a warning in its own right, carrying elevated risk of both COPD progression and cardiovascular disease even before any formal diagnosis exists. Pre-COPD and PRISm both belong to phase 0. Neither has a COPD label attached to it. Both deserve clinical attention. If you are a smoker or an ex-smoker with a cough that has lasted more than 8 weeks, do not dismiss this as a winter cold. That is a reason to request a spirometry test. 15 minutes and it can tell you something that changes the next 20 years of your life. Phase 1, and this is where the most damaging word in COPD management creates a false sense of security for patients and sometimes for doctors. Phase 1 or COPD gold stage 1, FEV1 above 80%. The report reads mild airflow limitation. Mild. That single word does real harm. Because mild on a spirometry report does not mean low risk. It means the airflow limitation is in its early measurable stage. It says nothing about your symptom burden, nothing about your flare-up history, nothing about which ABE group you are in. Phase 1 patient in group A, low symptoms, no flare-up history, is at genuinely lower risk right now. A long-acting bronchodilator, stopping smoking, and a structured annual review is often the right starting plan. But a phase 1 patient in group B, breathless on stairs, poor exercise tolerance, struggling daily, needs more than reassurance and a reliever inhaler. They need a combined long-acting bronchodilator, a proper symptom assessment, and a management plan that reflects their actual daily experience. And here is the question that matters most at phase 1. Have you had any flare-ups this year? Any hospital admission for your chest? One hospitalization, just one, places you in group E, regardless of what your spirometry says. That one event changes your risk profile immediately and completely. The word mild describes your breathing test result. It does not describe your situation. Before phase 2, and phase 2 contains the most important data point in this entire video, I want to pause and tell you about something I have built specifically for people watching videos like this one. I run a lung health community where I send a weekly newsletter with practical evidence-based information for people living with COPD and other lung diseases. No medical jargon, no information overload, just the things that actually matter for managing your breathing day to day. Explained clearly by a respiratory consultant who works with these patients every single week. The link to join is completely free and it is in the description box below. Now, phase 2. Phase 2 is the phase where one piece of research data changes everything about how urgently you need to act. Most patients at this stage feel like they are coping, but the data says something different. Phase 2, goal stage 2, FEV1 between 50 to 79%. Symptoms are real now. Breathlessness on exertion, stairs take effort, you have had chest infection needing antibiotics. A reliever inhaler is in the picture. But here is the game-changing part most people miss. When researchers looked at how much lung function a single severe exacerbation cost across every stages of COPD, the greatest loss was not in the sickest patients, it was in the patients with mild COPD. The earliest stages, the people who felt they still had time. A severe exacerbation in a mild COPD patients causes an excess decline of 87 milliliters of FEV1 compared to a similar mild COPD patient who did not have that exacerbation. At the moderate stage, that excess drop is 20 milliliter. At the very severe end, just 9 milliliter. Not because the flare-up is less dangerous at the severe end, but because those patients have already lost most of what they had. There is less to lose. One severe flare-up at the mild to early moderate stage costs you nearly 10 times more lung function than the same event at the most severe stage, and that lung function does not come back. And there is more. Two moderate flare-up in a single year, not severe ones, moderate, increase the risk of death by 80%. One moderate exacerbation increases the risk of a future hospitalization by 21%. Phase 2 is the intervention window. A combined long-acting bronchodilator reduces exacerbation frequency. Stopping smoking slows the rate of decline, not stops it, but slows it enough to change the trajectory for the next 10 to 20 years. That 87 milliliter figure is not just data. It is the argument for acting at phase 2, not waiting to see how things develop. But phase 3 is where the most dangerous track closes around most COPD patients because it arrives wearing the disguise of finally being managed. Phase 3, gold stage 3, FEV1 between 30 and 49%. For the majority of my patients, this is the first time a formal COPD diagnosis appears in their notes. Breathless on minimal exertion, getting dressed takes effort, and admission to hospital has happened, inhalers are in place, and there is a feeling finally of being managed. That feeling is a trap. Half of all patients die within 4 years of their first serious hospitalization for COPD exacerbation. Most patients at phase 3 have already had that first exacerbation. The clock has already started. Two moderate flare-ups this year, 80% higher risk of death. One moderate flare-up, 21% higher risk of another hospitalization. At phase 3, Group E is not a possibility. For most patients, it has already arrived. And Group E at phase 3 demands triple therapy, a combination of two types of long-acting bronchodilator plus an inhaled steroid. Not a reliever used when breathless, not a single inhaler. Triple therapy, reviewed regularly by a specialist, not managed from a repeat prescription alone. Because here is what the data also shows. With each exacerbation, the gap before the next one shortens. The window of stability narrows. Each admission makes the next one more likely and closer. The pattern does not reverse on its own. Phase 3 is not managed COPD. Phase 3 is where the difference between patients who stabilize and patients who spiral comes down almost entirely to how precisely they are being managed. Phase 4. And this is where the story of COPD stops being only about your lungs and the data about what is actually happening to your body. With every flare-up becomes impossible to look away from. Phase 4, gold stage 4. FEV1 below 30%. Possibly on home oxygen, multiple inhalers, daily life has become a series of carefully managed distances. But here is something most phase 4 patients have never been told, and it comes directly from research that tracked thousands of COPD patients through their exacerbations. Every serious flare-up is a cardiovascular event as much as a respiratory one. Within approximately 5 days of a moderate COPD exacerbation, the risk of a heart attack doubles. Within 10 days, the risk of a stroke increases by 40%. And in the 30 days following a serious flare-up, the risk of a major heart or lung event is approximately 4 times higher than normal. 4 times for 30 days every time. Your heart and your lungs are in constant biological conversation. When your lungs are under severe inflammatory stress, that inflammation does not stay in the chest. It drives changes in the blood that makes clotting more likely, puts strain on the heart muscle, and raise blood pressure. Patients at phase 4 do not only die from respiratory failure, they die from heart attacks and strokes that the flare up triggered. And the frequency of exacerbation compounds the risk in a way that is hard to fully absorb. Patients who have had 3 or more serious exacerbation carries the risk of death 4.3 times greater than the patients who have had none, not slightly higher, 4.3 times. Three things change the trajectory at phase 4. Specialist-led triple therapy, pulmonary rehabilitation, and preventing the next exacerbation. Because at phase 4, that prevention is the most powerful thing medicine can offer. Now let me bring the whole picture together, because 5 phases are not just a description of what happens. They are a map, and a map is only useful if you know where you are on it and what direction to move. Phase 0, pre-COPD. Your spirometry is normal, but your small airways are already changing. If you are a smoker with a cough lasting more than 8 weeks, get tested. If your FEV1 is below 80% but your ratio is normal, that is PRISm, a separate warning that deserves clinical attention in its own right. Phase 0 is a phase where stopping smoking changes everything. Phase 1, goal stage 1. The word mild belongs to your breathing test result, not your risk. Find out your ABE group. Group B or Group E at phase 1 means combined long-acting bronchodilator, possibly a triple inhaler, and a proper plan, not a reliever used when needed. Phase 2, goal stage 2. This is your intervention window. One severe flare-up at this stage costs nearly 10 times more lung function than the same event at severe end of the spectrum. 2 moderate flare-ups in a year, 80% higher risk of death. Act here. This is the phase where the most is still possible. Goal stage 3. Half of patients die within 4 years of their first serious hospitalization. The clock starts with that admission. Triple therapy, regular specialist review. The management here needs to be more precise than anything that came before it. Phase 4, goal stage 4. Within 5 days of a flare-up, heart attack risk doubles. Within 10 days, stroke risk rises 40%, 4 times the cardiopulmonary event risk in the first 30 days. 3 or more serious exacerbation, 4.3 times the risk of death. That is not only a lung condition anymore. And for Margaret, the patient from the beginning of this video, she is now 14 months post-discharge. Triple therapy, pulmonary rehabilitation, she knows her ABE group, she knows what a flare-up looks like before it becomes a hospitalization, she checks in with her lung health community for her weekly information, and she has not been admitted since. She told me at her last review, "I just wish someone had drawn this out for me years ago." And that is precisely why I make these videos and why I built the community. One final thought before I go, because the most important thing I want to leave this video with is not a number or a phase level. A COPD diagnosis is not a death sentence. It is a signal to be more precise, more deliberate, more informed about what is happening and what can be done. The patients who do best with COPD are not the ones with the mildest disease. They are the ones who understand their condition clearly enough to advocate for themselves at every appointment, and who have access to reliable information between those appointments. That is what the lung health community is for. A weekly newsletter with practical respiratory guidance, free educational resources built specifically for COPD patients, and a Master Your Breathing course designed to give you tools you can use right now, not in 6 months when your next appointment comes around. Join completely free through the link in the description box below. If this video gave you a clearer picture of your COPD than a clinic appointment ever managed, please share it, not for the channel, because the patients sitting in that 4-year survival curve are not unlucky, they are underinformed. And you sharing this might be the reason someone finally understands where they are and what to do about it. If you would like to discuss your own respiratory care with me directly, I see patients privately at Pall Medical in Liverpool and Manchester, and at the Cromwell Hospital in London. The link to book is in the description box below. Now you know which phase you are in and what your exacerbation history is really telling you. But there is something even more important if you are at phase 3 or 4 right now. On the 26th of March 2026, NICE approved something that had never existed in COPD medicine before. And most patients and most GPs still don't know about it. Check out this video where I show you exactly what the new NHS COPD injection is, whether you qualify, and the one number in your blood results that decides everything. See you on the other side.